sorry. But good evening to everyone and welcome to the McSwain Trauma Thursday Talk. We appreciate your taking the time to be here with us tonight and joining us. Very sorry. I'm Mary McSwain. I'm the Executive Director of the McSwain Trauma Education Project. I'm here with Will Chapleau, who is the Chairman of MTEP, and also Steve Mercer, who is the Treasurer. Tonight, we are very honored to have Dr. Jeff Salomone here to give his presentation on traumatic cardiopulmonary arrest. Will is moderating the talk tonight, and Steve is monitoring the chat questions. Please mute yourself during the talk so that there's no distracting background like a big dog barking in the background. And feel free to use the chat feature for questions and comments during the presentation. Steve will get back to those questions and comments as needed. There will be an opportunity at the end of the program for questions and comments. Let's see, after tonight's presentation, you will receive a survey. Please tell us, asking us how you enjoyed this topic. Please tell us other topics that you're interested in. We are here for you. We are not a cookie cutter organization. We want to know what you want to hear, and that's what's most important to us. If you're interested in verifications or certifications that you were here for continuing education for trauma talk in your state, please email that request to general@mcswaintraumaedu.com. But please understand, again, it's holiday season for us, it's sort of like Christmas week. We will get back to you with those verification certifications as soon as we can, but it'll be a week at least. Also want to mention that MTEP is a nonprofit organization. We are only able to provide quality continuing education through donations. Please consider a tax-exempt contribution so that MTEP can continue its mission to provide quality continuing education. With that said, we are proud to have Dr. Jeff Salomone here with us tonight. Dr. Salomone graduated from the University of Nevada, Reno, and University of Nevada School of Medicine. He completed his surgery and surgical critical care fellowship in New Orleans and also served as Dr. Norman McSwain's residency director there. He relocated to Atlanta, Georgia to begin a 16-year tenure as trauma critical care surgeon at Emory Hospital, based at Grady Memorial Hospital. While in Atlanta, he served as Atlanta police surgeon for 15 years, caring for police officers injured in the line of duty. From there, he went to Arizona and was named the Director of Trauma and Surgical Critical Care and Trauma Medical Director for Banner Desert Medical Center, where he led the organization and eventual American College of Surgeons verification for adult level 2 and pediatric level 2 trauma center. While working his way through medical school, Jeff earned his certification as a paramedic, and EMS has been a central theme of his career. He was Associate Medical Director for the Pre-Hospital Trauma Life Support Program for more than a decade. Myself and the other MTEP board members have known and respected Jeff for a very long time, and we are privileged to have him here with us tonight. Thank you so much for being here, Jeff, on your presentation of traumatic cardiopulmonary arrest.
Mary, thank you so much for that nice introduction. And to you and Steve and Will, thank you for the invitation to speak tonight. Steve, I think you have my slides. And there will be time for live questions and answers at the end of the presentation. If you have a question or need clarification as we go through the presentation, please send the message via chat and Steve will make sure it gets addressed. All right, Steve, if you could advance the slides. So there's always a disclosure slide. I have no financial disclosures, but one of the themes I want to emphasize tonight is that you need to follow your local protocols and online medical direction. And I'll circle back with this at the end of the presentation, but I think throughout the presentation, you'll see why I'm stressing that. All right, next. Traumatic cardiopulmonary arrest has a dismal prognosis. We know that MCA, or medical cardiac arrest, the published survival rates are between 5 and 10%. Some communities have up to 15 or so percent a discharge from the hospital of pre-hospital cardiac arrest. However, traumatic cardiac arrest is much, much worse. There's a National Trauma Data Bank analysis of 9 years of blunt and penetrating trauma victims arriving in the emergency department in cardiac arrest. And there were over 24,000 patients included, and almost 97% were pronounced dead on arrival. There were only 1% who made it through the ED long enough to be admitted to the hospital, so about 246. And only a third of those that were admitted to the hospital survived to discharge. So we're talking about a survival rate of something like 3 in 1,000. From traumatic cardiac arrest. There's no information on neurologic outcome for those patients, but you can see that, medical cardiac arrest is something like 20 times more survivable than traumatic cardiac arrest in the field. Next. So the pathophysiology of traumatic cardiopulmonary arrest differs significantly from the pathophysiology of medical cardiac arrest. And that is in the medical situation, there's usually a primary cardiac event. There's an arrhythmia, myocardial infarction that stimulates an arrhythmia leading to the cardiac arrest. And it's usually a sudden event. Sudden death syndrome is what we're all taught. Whereas traumatic cardiopulmonary arrest many times occurs much more slowly. And the 4 mechanisms that are most common to lead to cardiac arrest in trauma are hypoxia, for example, an airway issue or pulmonary or chest wall trauma that interferes with your ability to oxygenate your blood. The second one is a massive neurologic injury, whether it's a gunshot wound to the brain or a very high spinal cord, and the patient's spinal cord injury and the patient's unable to breathe. A direct injury to the heart, a stab wound or a gunshot. And probably the most common of these is loss of preload. And that's usually bleeding, hypovolemic shock, but occasionally it can be a tension pneumothorax or cardiac tamponade. And in trauma, it can be a combination of several of these things. So as we go through this evening, just keep in mind that the pathophysiology is different compared to medical cardiac arrest. All right, next. We remember from our advanced cardiac life support, the PEA algorithm or asystole algorithm, there are a number of H's and T's that are taught. And in the pre-hospital setting, there are really 4 of these that are potentially reversible causes for traumatic cardiopulmonary arrest. And the 2 H's are hypoxia and hypovolemia, and the 2 T's are tension pneumothorax and tamponade. We'll come back and address those later in our discussion about management of the problem. Next. So in terms of presentation of the patient who's in traumatic cardiopulmonary arrest, the patient typically presents in either asystole or in pulseless electrical activity, PEA. I don't like to call PEA a rhythm because you typically have a cardiac rhythm with PEA, and PEA is more of a condition to me. You've got an electrical pattern, but you've got no circulation. You've got no pulse. And so I always stress with my PAs that we need to know, is it a bradycardic PA, or is it sinus tachycardia PA, or is it an agonal cardiac rhythm that's going on? So the rhythm can be many different things in pulseless electrical activity. Whereas in medical cardiac arrest, it's typically VFib or VTAC. And again, in recent years, the last decade or so, there's been a huge emphasis on two things in treating the out-of-hospital medical cardiac arrest, which has been shown to improve survival. And those two things are high quality CPR with minimizing interruption. Back in the day, some of us trained, you used to demonstrate how much of a man you were by how long you could do CPR. And now it's just the opposite. You want to change people as quickly as possible so you can maintain high quality CPR through the resuscitation. The thing that's probably more important than that is rapid electrical defibrillation. So a medical cardiac arrest is typically VFib or VTAC if it's witnessed. And so immediate electrical intervention to try and reverse that process. Next. So one of the first questions we need to ask is, should we even code the patient? And we can go down the rabbit hole of lights and siren transport. It's dangerous to providers. It's dangerous to other people who are on the streets. Very few of us are strapped in the back of the ambulance while we're doing CPR en route to the hospital. And so were the ambulance to get in a car accident, motor vehicle collision, then the occupants of the box could be injured. So we want to think about whether or not there's even any value in attempting to resuscitate the patient. And I think we're all familiar with the first two, the injuries that are incompatible with life. And, this would be, obvious mortal injury, a hemicraniectomy or a decapitation, or torso's been ripped open or something like that. So clearly we wouldn't start a resuscitation in those circumstances, or if started by a bystander, we shouldn't continue it. And then obvious prolonged cardiac arrest, patients who have evidence of dependent lividity or livor mortis, or even rigor mortis, we would not want to use CPR and resuscitative techniques. And there are national guidelines that have been published by the American College of Surgeons and the National Association of EMS Physicians that look at when to withhold CPR in traumatic cardiopulmonary arrest. And that's where I've pulled this information. So the first two apply for both adults and peds. The pediatric document was done by the American College of Surgeons Committee on Trauma in conjunction with NAEMSP and the American Academy of Pediatrics. So there are pediatricians participating as well. So with blunt trauma in adults, if the patient is apneic, pulseless, and has no organized rhythm, and there are a lot of patients who are victims of blunt trauma who are worked in this country today that meet that criteria, who probably shouldn't be worked. And this position statement has been out for more than a decade and has been slow to filter in. But you get to the scene of a car crash and your patient's not breathing, they have no pulse. First thing I'd do is slap EKG leads on. And if they don't have an organized rhythm, to me, an agonal idioventricular rhythm is not organized. Are they bradycardic? Do they have tachycardia and PEA? That may be workable, but if it's a systole or an agonal breathing and rhythm and they're apneic and pulseless, those patients are dead. there's no point in attempting resuscitation. Penetrating trauma has a slightly higher success rate if you can rapidly get the patient to a place where surgical intervention can be done. But that's typically penetrating trauma to the chest. If it's penetrating trauma to the abdomen, less likely to survive. If it's penetrating trauma to the extremities that led to exsanguination and the patient coded, those patients are extremely unlikely to survive. But we still think about an apneic pulseless patient. And for penetrating trauma, we talk about signs of life. Is there any spontaneous movement, pupillary response, or organized EKG activity? Very similar to the blunt trauma. And if the answer is they meet these criteria, they shouldn't be resuscitated. One of the reasons the criteria differentiate or differ a little bit between blunt and penetrating trauma is the evidence based upon which these recommendations are made. So some included signs of life and the blunt trauma did not. Moving on to the pediatric patients, everyone tends to give kids a little higher benefit of survival. We do a little bit more, try a little bit harder. But if there are no witness signs of life and CPR is not initiated with, I'm sorry, this should be a witnessed cardiac arrest. And if there are no signs of life and CPR is not initiated within 5 minutes of the arrest, or CPR is not initiated, then pediatric patients aren't viable either. So imagine now we've got a patient who doesn't meet any of these criteria, and we're now going to attempt resuscitation. Next. So we've talked about the pathophysiology of medical cardiac arrest and the emphasis on CPR and electrical defibrillation. The differences in pathophysiology lead to differences in management for traumatic cardiopulmonary arrest. And I'm going to walk through a number of these. Next slide. So with traumatic cardiac arrest, it's usually a slower decline than a R-on-T syndrome or the patient going into an abrupt VFib arrest. And as the patient's bleeding out, as the patient's becoming more and more hypoxic, the sympathetic nervous system is activated, epinephrine's released. And at the time of the arrest, these patients are typically significantly vasoconstricted from their own inherent release of epinephrine. And there's a large question about whether any additional epinephrine may be of any benefit at all. Next slide. So not only is there a question of whether epinephrine may be of benefit, there's actually data that shows that in traumatic cardiopulmonary arrest, administration of epinephrine can be harmful. So in 2021, there's this meta-analysis, and a meta-analysis is where you take 4 similar studies and combine them together, combine the data together and reanalyze it so you have a stronger study because it includes more patients. And what this study found was that patients who had received epinephrine in their pre-hospital traumatic cardiopulmonary arrest showed no improvement in return of spontaneous circulation. And they came to the conclusion that epinephrine may not improve short-term survival. That is, there were a group of patients, about 200 out of 1,100, that received no pre-hospital epinephrine, and they had slightly better outcomes than the patients who received epinephrine. And then in this next study, the observational study, which is going back and looking at a chart review, they looked at the 7-day survival rate. And again, the patients who received no epinephrine were about 7 times higher to live for 7 days than the patients who received epinephrine in the pre-hospital setting. So their conclusion was that use of epinephrine was significantly associated with decreased 7-day survival. And I know that the EMS committee of the Committee on Trauma has been looking at this as well. A number of centers had pooled their data, and the data is being analyzed. And I know this was presented as a poster at the NASP meeting a couple of years ago, but I don't have access to their data as it's not been published yet. Next slide. So just as a summary of that is that the role of epinephrine in traumatic cardiac arrest is questionable at best and possibly harmful. The next thing is chest compressions. The bottom right shows how CPR works. You know, an effective compression compresses the heart in between the sternum and the spine, squeezes the blood out. Then when you fully relax, blood passively fills the heart. And again, high quality CPR is believed to circulate this blood and improves coronary artery perfusion and improves cerebral perfusion. And so the two things you're hoping, hoping the brain survives while you are trying to get the heart started again. In traumatic cardiac arrest, you can imagine that if a person's lost 40 or 50% of their blood volume before they coded, this is going to be completely ineffective. CPR is of no use. And there's an animal model that was published of hemorrhage-induced traumatic cardiopulmonary arrest. And it showed that the animals that got chest compressions before they were attempted resuscitation did worse than animals that did not get chest compressions. And then there's another study that's been published that found 100% mortality in patients who received chest compressions versus 94% mortality in those who didn't. And there are places in this country, one of the places that stands out to me is Philadelphia's published a lot about their penetrating trauma. And when a police officer gets on scene, finds a victim who is in extremis rather than waiting for EMS arrival, they've thrown the patient in the police squad car and taken them to the closest trauma center. So they're really not getting care during transport. And that would be a place where this sort of result comes, that the patient's not getting compressions during transport and yet goes in, gets a thoracotomy and has a better outcome than somebody who's gotten chest compressions. So why chest compressions may not be helpful? The next slide looks at that. So as I've mentioned, chest compressions can be ineffective with marked hypovolemia. And as I mentioned, hypovolemia is probably the most common issue leading to traumatic cardiac arrest. There's the theoretic issue of chest compressions worsening thoracic trauma. Clearly, if there are rib fractures, broken ribs can puncture the lungs, cause more bleeding. Potentially, there are even in medical cardiac arrests, there's stories of a fractured sternum lacerating the right ventricle of the heart and things like this. And then one of the other thoughts here is that if you're so focused on doing chest compressions, it may distract you away from some of the more effective strategies. So the next slide begins to look at those. So is there one before that, Steve? Did that jump to? Oh, no, I'm sorry. The fluid resuscitation. So in recent years, even with, I remember back to our 6th and 7th additions to the pre-hospital trauma life support textbook, this was early data from the Iraq War. We were looking a lot at the role of crystalloid. And in the last 10 to 15 years, there's been a significant trend towards using less crystalloid in the field. The pop the clot concept, that if you take a hypovolemic patient, raise the blood pressure, they can start bleeding again. And in experimental animals, those animals have a lower survival rate. So that led to the concept of balanced resuscitation, providing some fluid to maintain perfusion. A mean arterial pressure is 60 to 65, but not restoring normal blood pressure. Even more recently, there's been this concept of damage control resuscitation. And damage control resuscitation is focusing more on blood administration rather than crystalloid. And there's a lot of data that suggests that crystalloid may be harmful. Both lactated ringers and normal saline may be harmful for trauma patients. So we'll come back and address that in just a few slides. Next. So one of the most important things, if you're going to work this traumatic cardiac arrest, is getting this patient en route to the closest appropriate facility. And by appropriate, we're talking about the highest level trauma center you can get to. And what you need to know, I think every EMS provider on the street needs to know in their community, which facility has immediate surgical capability. Do the surgeons stay in house? Are there surgery residents who can start resuscitation? Because trauma is a surgical disease, and for these patients to survive, they need emergent surgical intervention to make the right decisions. So getting the patients en route to the hospital. And the standing joke we've used for many years that the best fluid for pre-hospital traumatic cardiac arrest is gasoline or Jet A fluid to fly the patient to the trauma center as quickly as possible. Next. So we're back to some other management considerations, the potentially reversible causes. So now we've thought about getting the patient en route to the hospital. Now what can we do for the patient while we're en route? And we need to think through these 4 things and see if they apply to this particular patient. So next slide. So the first is treating hypoxia. And over the years, I've become less and less a believer in endotracheal intubation for trauma patients. I believe whatever way you can secure an airway as quick as possible, and that would be a supraglottic airway. There's emerging data. There's data presented last month at the Eastern Association for the Surgery of Trauma that trauma patients who are in extremis, who are intubated before the operating room, have a higher mortality rate. So again, that's something we always empirically thought, and I was trained this under Dr. McSwain at Charity, would, get the patient to the operating room. We continued this at Grady, and then induce the patient when the patient's prepped and you're ready, intubate the patient and slice them with the scalpel so you can get in and get to bleeding. Because once you start doing, the reason there's a caution sign next to ventilation is once you start doing bag valve mask, positive pressure ventilation in a patient who's hypovolemic, you're decreasing venous return to the heart. So it's similar to a tension pneumothorax. There's less blood flow back to the heart. And that's why a lot of these patients code when you pull out the RSI drugs and you give them to the patient. So if they're breathing, again, we want to provide oxygen and even blow-by oxygen. Many of you know with your airway skills that you can still oxygenate a patient without bagging them to some extent with high flow oxygen. and maintain a pretty good oxygen level in those patients. So we do want to maintain or do want to intervene for hypoxemia. And our goal would be a oxygen sat of 95 to 100%. But again, if a patient's in cardiac arrest, it's going to be hard to get an accurate pulse ox reading. The next slide. So a little bit more about damage control resuscitation. The components of these is one, control bleeding. So apply pressure dressings to bleeding areas. If they're in traumatic arrest, they're not going to be bleeding much. Apply tourniquets. Pelvic binder has been considered. For me, the jury's still out on the role of the pelvic binder in the pre-hospital setting. There are times I've seen EMS crews, frankly, miss an unstable pelvis when a binder could have been beneficial, and other times when binders are put on, the patient doesn't have a pelvic fracture at all. So again, I'm not being critical of EMS providers. They're working in an environment where it's hectic and they don't have the benefit of x-rays that we do in the emergency department. Blood products are much more important than crystalloid, and there's been a focus on moving to blood much more rapidly. The old ATLS used to treat 2 liters of crystalloid and then consider blood. Advanced trauma life support is now focusing on blood much earlier in the resuscitation. And then in the last 5 years or so, there's been a move from packed red blood cells to whole blood. And many trauma centers now have whole blood. And there are a couple of pre-hospital services in the country, and those around San Antonio, Texas, are ones I think of. Air medical programs carry it's easier to carry packed cells than whole blood, but whole blood is still something that should be considered if it's available, and packed cells. So we end up, whereas we used to give liters and liters of crystalloid, we end up giving very little crystalloid and lots of blood products in our massive resuscitations these days. And then maintaining some degree of hypotension until your hemorrhage is controlled. And we've spoken a little bit about that. So that's thinking about hypovolemia. So blood products, if they're available. Next. All right. Tension pneumothorax. So if the patient has good bilateral breath sounds, you know, the benefit to doing needle decompression is questionable. However, if you can't hear breath sounds or not getting good breath sounds, it potentially could be life-saving. There's been significant data in the last 10 to 20 years showing that many needles carried by EMS providers aren't thick enough to make it into the, or long enough to make it through the muscle on a well-muscled man, or subcutaneous fat on obese patient population. And so you may not even decompress the pleural space with standard needle decompression. There's been an emphasis in the military and some air medical crews. This concept of a finger thoracostomy was first developed in the London pre-hospital setting, but they're physician staffed ambulances in London. And rather than putting a chest tube in, there's an incision that's made and blunt dissection into the pleural cavity just to release the pressure. There's no foreign body, no chest tube that's put in. The tube is not nearly as important as releasing that pressure. And so there's some data to suggest that the finger thoracostomy is more effective and as safe as needle decompression. But I think there's more study. There are a number of trauma surgeons who I think are critics of this, and then there are a number of people who are supportive of this concept. The next one, tamponade, is also controversial. In the most recent version of the advanced trauma life support, they really de-emphasize the role of pericardiocentesis. for physicians in the emergency department and emphasize that definitive care for cardiac tamponade is performed by a surgeon through a thoracotomy. So opening up the chest, and again, most of the time this is an injury to the heart that's causing the blood around the pericardial sac and impairing the heart's pumping activity. And so a rapid thoracotomy would be appropriate. But if in the EMS setting, you are credentialed to do pericardiocentesis, making the diagnosis in traumatic arrest is very difficult. Blindly sticking a needle towards the heart. When you aspirate blood, you're never really sure whether you're in the pericardium or whether you're in the ventricle of the heart. And so, for a patient who's in cardiac arrest, it's unlikely to significantly injure them, and it potentially could be life-saving. So that's something to consider. Ultrasound guided if you have access to that. All right, next slide. So the next thing to think about would be termination of resuscitation. Consider when no signs of life and no ROSC despite appropriate field care. Now, earlier I emphasized the role of rapid transport, so you shouldn't be spending 15 minutes at the scene doing a resuscitation of a patient with a traumatic cardiopulmonary arrest. But imagine a patient who's partially trapped and you're able to start resuscitation, but by the time you get the patient released, you've got no response for 15 minutes of resuscitation. That would be a patient I would think about not continuing a resuscitation on. And depending upon your protocols, this may require physician oversight. Again, saving the risk of a lights and siren transport with a potential motor vehicle collision. All right, next slide, Steve. I want to acknowledge this presentation was based upon a paper that Brian Bledsoe asked me to collaborate with him on, published in JIMS a month ago. If you go to jims.com and then search traumatic cardiopulmonary arrest, this is the second document that comes up. The studies that I've spoken about in this presentation come from, they're included in the bibliography to this article. So thank you to Brian for being a thought leader for many years in EMS. Some of you may have used his textbook. Again, a lot of this was his ideas of helping to pull this together and then me pulling the surgical side of things in. So one thing I did want to spend a minute talking about would be exceptions to what I've just gone through talking about. To me, I can think of two situations where I would treat a traumatic cardiac arrest like a medical cardiac arrest. And one would be where you think the inciting etiology is really a medical cardiac arrest. That is, you arrive on scene, it's a middle-aged elderly patient. There's minimal trauma to the vehicle, yet the patient's in cardiac arrest. And there's minimal trauma to that patient. Could they have had a primary medical problem that led them to have a low energy, foot comes off the gas, they roll into the median and have a low impact collision. So those are patients that I think are an exception to this role. And then the last one in the last 2 months has been a lot of talk about commotio cordis since the young athlete, National Football League player, suffered the cardiac arrest on the field. My gut feeling is that was not commotio cordis. Again, commotio cordis is when you get an impact to the precordium, the sternum, at the specific point in the EKG cycle that puts the heart into VFib. Moment you go into VFib, you lose consciousness within about 15 seconds or less. And so the video showed this guy being hit and then getting up and then collapsing. So my gut feeling, and several other people I've talked with, is that it was not the result of commotio cordis. But if you have the history of somebody who is struck in the heart, collapses, and CPR started, those would be patients you would treat as a medical cardiac arrest as well. All right, the next slide, Steve. So I again wanted to throw this up because I didn't want you to roll into your next, bring your next traumatic cardiac arrest patient in with, the smart trauma nurse asking you, how much epinephrine did you give? And you said, none. I just heard this guy on YouTube talking about this. Or why aren't you doing chest compressions on this patient? Well, they don't help. What I'm talking about is some controversial and cutting edge stuff and telling you about the data. Could we do better? And so I don't want you to get in trouble. You need to follow your protocols till they maybe catch up. So at this point, I will entertain questions. I think that's the next slide.
Jeff, I'll take lead on that. I've got some questions coming in from the audience already, and I'm going to bring them to your attention. But you kind of leaned on something as we were coming through here. While you say that you're looking at controversies, and I think it's important to talk about how controversy sometimes has less to do about whether or not it's a fact, but more to do with emotional tugs left and right, and that EMS has been slow sometimes to recognize what the science is telling us. Do you care to comment on that?
I considered adding another slide in this where a post I saw from an EMS physician. I think in recent years, all of us had, those of us who've been around since the amiodarone debacle with the American Heart Association. We questioned some of the data. I need to say that the ATLS textbook for traumatic cardiopulmonary arrest says you do chest compressions. Probably the PHTLS textbook and probably ACLS says the same thing. It takes basic science. People would say, well, it's unethical to withhold epinephrine and to do a study. Well, we've got some pretty good data now that raises the scientific question when it begins to not just not help, but actually potentially harm a patient. Then that really does raise the question about whether it is ethical or unethical to withhold epinephrine. It may be more ethical to withhold the epinephrine if it's causing harm. So that's a long-winded response, Will, for your question. And that is, it takes time. I think you need to see the science, and then the thought leaders need to begin, it takes people to challenge the status quo. And sometimes the sacred cows make the sweetest burgers, they say.
Jeff, I think was an excellent response. And I think it's important that all of these conversations are not meant to slam people back and forth. It's just like, can we look at this together and figure out what the best way to do things are? I'm going to give you some of the questions from the field here too, and people keep putting them up, and I'm going to bring them to Dr. Salomone. One of the questions was, Jeff, does the presence of an ET tube make any difference in whether or not you're deciding to resuscitate or not, or to call
it? For me, it wouldn't. I don't think it would make any difference to me. Again, as my years have gone by, American Heart has de-emphasized the role of advanced airway protection in medical cardiac arrest, and I think its role in traumatic cardiac arrest is questionable. Again, anything that delays time at the scene or increases time at the scene and delays transport to a surgeon in the trauma center, to me, is something that potentially affects outcome.
I think that's an important point you're making, Jeff, because when you made that point about the numbers being so bad for intubated patients, it kind of begs the question, is it because we're taking too much time? And I think that's an important consideration.
Right, right.
Another question.
And just on that point, Will, if people want to think about this, a number of years ago, I know the PH-TLS people know this, but the rest of you may not be aware of this study. A number of years back, LA County USC Hospital realized that 18% of their patients were arriving in the emergency department by private EMS or private car and not by ambulance.
The taxi cab study.
So they actually thought this was a public health problem. We need to educate our public to call 911 and get an ambulance to the scene so their care is provided en route to the hospital. So they said, well, before we start this public education campaign, being good academic trauma surgeons, we should have some data. And so they looked back at the last couple of years of outcome of trauma patients transported. This was not traumatic arrest. It was all trauma patients transported to their trauma center. And those that were transported by private vehicle had a higher survival rate than those that were transported by the LA City Fire Department EMS program. And then when you dug into that, you found out that LA City was spending 25 to 30 minutes on scene with these trauma patients. And so again, the concept of, pre-hospital care started as an attempt to stabilize the patient at the scene, and that's appropriate for pre-hospital medical problems, but medical codes especially, because CPR is not very effective in the back of a moving ambulance. But here patients were doing worse. So then they did a whole lot of education for their EMS crews. And when they repeated the study, they now showed that the outcome, EMS crews were spending less time on scene, and now the outcome was pretty much identical between those transported with EMS and without EMS. And so, rapid transport is a huge thing. So if any of you freaked out a little bit when I mentioned Philadelphia, where they throw penetrating trauma in the squad car and run them to the hospital, they've had pretty good outcomes with that approach. And so if you're doing anything that's slowing down getting the patient to a surgeon, you're potentially not helping your patient.
Great points, Jeff. And I do that talk about, is it really that simple? It's kind of the same thing. Some things are not very complicated at all. We just have to be smart about the time involved. There's another question here for you, Jeff. First of all, they said great presentation. There's a lot of those comments, and it clearly is. Have you seen preliminary data on the field use of blood or blood products, or is it too early yet?
There are people who've published their experience, but I've not seen any outcome data yet that shows that patients do better with pre-hospital blood than not. Mary has tasked me with preparing a lecture on pre-hospital blood administration for an upcoming MTEP conference in Brazil. Unfortunately, I don't get to go to Brazil. I get to sit in Arizona and do my presentation, but I'll be looking at that topic for that.
Looking here. Jeff, one of the things you talked about is, and you and I talked about privately earlier, is that EMS is not a neophyte anymore, that it's been around for a long time, and it's time that we look at things more critically. There were assumptions made when EMS started that were just that, they were assumptions, and that we have to look hard at many things that we've always done and we continue to do, but if they're not helping the patient, we have to be prepared to make some choices. would you comment on that in respect to what you've been talking about tonight?
Summarize that again.
Basically, that when EMS started, there were a lot of assumptions made based on models that were not pre-hospital, but otherwise. And over time, we're starting to challenge those because the evidence is challenging us that maybe those things don't work and we need to think differently.
Well, exactly. It's not just EMS, it's medicine in general. Surgeons especially are very traditionally oriented people. You know, you ask a surgeon why they do things, and a lot of times there isn't great data, but it's the way they've always done it. It's the way I've always done it. And a lot of us, you know, we need those people in the industry who are thinking and saying, you know, is there a better way to do things? And those of you who are old enough to remember the old debates between Ken Maddox and Norm McSwain, I think Dr. Maddox is one of his greatest roles is he would play the devil's advocate and he would stimulate discussion. He would ask the questions that got people thinking. Everybody thought he was this great naysayer, but I think his goal was truly to start conversation and make people think. You know, there's a lot of things about not just EMS, but medicine that, you know, makes you think about Tevye and Fiddler on the Roof. Why do we do it? Tradition.
It's funny you mentioned Dr. Maddox. We did a conference together once, and afterwards, I challenged him on his topic, and I said, "I feel like this is happening. You're probably right, but get me the data."
Yeah,
It's just he did not mind, you know, pushing your button and making you get into that stuff. Jeff, another thing you talked about, or actually a lot of the things that you talked about, is gives you the sense that it's important for us to make decisions about what works and not what doesn't work, not just because it's not working or might be harmful, because we're wasting precious time on some of these patients. And how important do you think that is? I mean, you mentioned, you know, the best fluid is gasoline and that kind of stuff. But that keeps coming back to me as maybe one of the most important things in some of our most critical patients, that if it's not working and potentially harmful, we don't have that much time to be making those kinds of mistakes.
Exactly. There are, you know, there's some patients that arrive in extremis and code right after they get to our trauma bay. And we think if we only had 5 to 10 more minutes earlier, we may have been able to reverse things. And I'm not telling you not to start IVs, because having a good 14 or 16 gauge IV in a large vein ready to hang blood as soon as you hit the emergency department, if you're able to get an IV established in the pre-hospital setting, that saves time in the ED where you have blood. So there is some opportunity there.
One comment up from Dave Pecora put up 911 study. I'm not sure what his point was, but you might understand what he's talking about. I'm not certain.
I saw that. I don't know if he was asking for a reference or what he was getting at there.
Okay.
Will, if I can jump in just for a second in there, and Dr. Salomone, you were talking about working with your services medical director and doing protocols. One of the things that I would direct them to help them is the National Model EMS Clinical Guidelines has some model language, everything they use for protocol development for resuscitation for both traumatic cardiac arrest and medical cardiac arrest, and when to stop resuscitation. That's in the 2022 version of the National EMS Clinical Guidelines. It can help them, which is a summary of what you talked about from the NAMSP and ACEP papers.
Right. Excellent.
Oh, Dave's just mentioned it was the title of the Maddox studies. Okay. Jeff, we're down to like the last 3 minutes of this, and I want to give you time to close out with any thoughts you might have, but a lot of our audience is rural tonight. And while a lot of what we talk is kind of an urban time thing, we're close, we don't want to waste time, we can do all this stuff. One what do you think is the message for what we're learning to our rural audience about these patients who are in such bad shape and they have plenty of time, they just don't maybe have a lot of things that they can do?
Right, right. That's a difficult situation. There's certain trade-offs you end up with living in a rural setting. And it's great to live there, but not so great if you fall off the tractor and your arm's stuck in a grain auger and you're exsanguinating to death. So I always get into an internal debate about, do you go to the closest hospital or do you go 10 minutes further to a trauma center with a cardiac arrest? Well, if you go to the closest hospital, they're probably not trained how to manage a traumatic cardiac arrest. And so the outcome's probably going to be death. And if you go a little bit farther, you're going to get to a place where you've got the right people. And, there are many ERs that don't keep blood in their emergency department. It's standard practice in many trauma centers. So you have immediate access to blood. If you have the ability to administer blood in the field, you're in a rural setting and the helicopter's got blood, call the helicopter and rendezvous.
We're down to our last minute. Ron, you posted a question. Do you want to verbalize it to Jeff?
Which one? There were a couple, but
Your peer review question.
I'm sorry.
Your peer review question.
Yeah, I think that I keep on hearing the refrain, if it's not working, why not? What do we do? So what we've done, and I think I'd like to know Jeff's take on it. What do you see in today's EMS world? How do you see EMS providers interfacing with the hospital, with the surgeons and their peer review process? Because I think that just as we examine what we do in-house, the EMS providers can certainly benefit from their own outside review and then being brought into the hospital peer review. Where should we be going with that?
Yeah, I think that in the most recent resources document, I think the college, I'm sorry, not the most recent, but the one before that, there is an emphasis on a pre-hospital PIPS committee meeting at some point in time, whether it's monthly or quarterly. And one of the things I always wanted to do at my trauma center, but I never was able to because we got into the COVID situation, couldn't have meetings, was to do a quarterly meeting where we brought our EMS services, leaders from our EMS services together and invited providers as well, and went over cases where we saw opportunities in the pre-hospital setting. You need surgeons who are capable of educating EMS providers. Probably one of the most common mistakes I see is people misplacing needles when they're attempting needle decompression. And so that's where it takes a trauma surgeon when they have a moment to call the team in and just say, here, guys, let me walk you through where the needle should have been. And so providing real-time education is part of the PIPS process, but then going back through those cases where there's, esophageal intubation that's unrecognized, or there are other concerns that the trauma center had about pre-hospital care that could be addressed. And I think having some sort of meeting like that with ideally the medical directors of the EMS services and some of the providers, as well as the leadership, to carry that information back to the folks on the street. So Dr. Gross, I'd love to hear your comments on what I had to say tonight, where you, if there's anything you disagree with or have different thoughts about.
No, whoops. I think Bill was going to say enough. No, you know what? I think this has been a vexing discussion, a vexing point for years. You mentioned kids. I think if you want to talk about emotion, we know that this poor kid is dead, but you got to give the kids a little bit more chance. That's where the visceral emotions come out. I think pretty much you and I are on the same page with everything you did say tonight. I first of all, I thought it was an excellent talk. It was well organized. You put the information out that we really needed. I really believe that, and this is from my experience with the long green line downrange, I really do believe that both Kim and Jenkins have it pretty down pat with respect to transfusion of whole blood and somebody who's exsanguinating in the field. We've shown it in the desert and we're showing it here. I do believe that we need to be a little bit more cognizant of those who come in. You know, if they come in dead, they're going to stay dead. So we need to know when to stop. And I will make one other comment for all of us. When our medics come in, having worked somebody for 30 minutes in the back of a bus, and they arrive in the emergency department, and those of us who have been doing this for a while have already gotten the sense of things. You put the ultrasound on the chest and you call it. I would ask everybody to take a minute and pull the medics aside and say, you understand why? Are you okay with this decision? I think that reinforces, one, that they did the right thing, and two, that we are concerned about their thought process and their emotional well-being. And I'll let it go at that.
Ron, that's a good point, because I grew up in a small community of, just a few thousand people, and the volunteer fire department was the social arm of the community. And
Yep.
In those communities, I think, and we're speaking to a lot of those folks tonight, this is friends and neighbors taking care of friends and neighbors. And
That's right.
all of the things that we do, we know their help. We're working with them to make very difficult decisions. Always things do part of it at the same time. We push for the right things to be done. I think it's important too. I think that was a great point. I want to thank Dr. Salomone. This was a terrific presentation. A great audience tonight. Thank all of you for attending tonight and for your questions. We're going to continue to do this. As often happens when you try to tap on the best in the profession to make these presentations, we have to juggle our schedule from time to time. So I can't tell you who it's going to be next month, but it'll be a surprise. It'll be excellent. We'll have somebody for you, and we'll tell you who's coming up over the next few months. Join us the third Thursday of every month. We will always have somebody here. And if you like what you're doing, take a look at the foundation. Give $1, give $2, talk to somebody who wants to give more. The foundation has big plans to continue doing this kind of work in both live conferences and the stuff that you're doing with us tonight. Again, I want to thank Dr. Salomone for the time he put into this and for joining the team. Dr. Gross for always being here. I saw Dr. Kramer's out there, who's one of our previous speakers also. Thanks for being with us. And thank all of you. We can talk in the dark, or we can talk to people, and you guys are here, so we appreciate that. And thank all of you for your commitment to the profession. There's nothing I can say that would adequately thank you for what you do out there every day. And we're going to be here for you, and we'll continue to be here for you. Thanks very much. Thank you all. Good night. We'll see you next month.
Good night.
Good night.
Thank you, Jeff.
Thank you.
Good job, Dr. Solomon.
Thank you.
Absolutely.
Thank you a lot.
It was absolutely wonderful. We had a total of 122 participants.
Jeez.
Wow.
Yes, so that was, we had several that were under one participant name. So it was very successful. Thank you so very much. Thank you,
Yeah,
Steve.
the word-
Thank you, Will.
The word's getting out there. I hope,
Word.
I think we keep seeing it grow every month and everything. So I think that's great. I know. And Dr. Solomon and also Colonel Gross, I appreciate your comments about bringing EMS into the team. You both use that term in there. And I think that's one thing that is being missed out. Go back to MTEP's motto, from the streets to the surgical suites. We need to make sure that that everybody's a team member.
Steve, Colonel Sen, the founder of the American Military Surgical Association, one of my favorite quotes: "The fate of the wounded rests in the hands of the one who applies the first dressing."
You got it.
You can't say it any better than that.
Right, but I think that we've allowed situations and egos and everything to get in the way and to have dividing lines out there. We need to wipe those lines away in there and come back into the patient care. That everybody's a player in this, and everybody has something to contribute to that patient.
Absolutely.
And I agree, Ron, with what you said, and also Will, and I think that would be a great trauma talk, future trauma talk, is to how we can be advocates to open the conversation between ER physicians, between trauma surgeons, and getting the feedback back to EMTs. I mean, it's Ron, just like you said, do you understand why? And I think that's a great subject for a future trauma talk, and something that I know that I worked really hard on the hospital side to increase that communication so that EMTs understood.
I think the concept of peer review, from when it first started over a century ago to where it moved to over the first 100 years and where it has come to today, morbidity and mortality conferences today are certainly not what I experienced when I was a resident at Delta. And I think that it has made a huge leap towards education and away from embarrassing people. And, I've actually done a fair amount of research on the peer review process. The medics, the pre-hospital personnel are so thankful when they have the opportunity to sit down and, you know what, your dad was a champion in this. Will is a champion in this. Steve, what you did a few decades ago makes you a champion. We need, as you said, to eliminate the barriers and the learning that goes into what we do and what pre-hospital folks do should be the same. The review process should be the same, and the outcomes will be much better.
We continue to have an audience of over 30 people, which is great. This is the longest that we've ever wandered past the time. And Jeff, I think that has a lot to say with the conversation you stimulated. So again, well done.
Thank you, Jeff. Great.
Thank you, Jeff. We appreciate you being here.
Thank you.
Jeff
Thanks
was
for
a great
inviting me.
paramedic teacher.
Thank you for your time.
Good to see you, Fred.
Good to see you, Jeff.
Hi, Fred. How are you?
Good, Mary. How are you?
I'm very well. I'm very well.
Good. Great
I've got
presentation.
ideas for the museum, but I'll email. So yeah.
Excellent.
Bye.
Take care, everyone.
All
Bye-bye.
right, folks.
Bye-bye.
Here.
Bye.
Thanks again, Jeff.
Bye.